There is a moment that happens quietly in clinics all over the world. A patient sits across from a doctor and says, "I've been taking iron for months. My diet is good. But my hemoglobin is still low." No drama, no panic, just confusion. Because most of us have been taught one simple rule. Low hemoglobin equals low iron, so if iron is added, hemoglobin should rise. But real life does not always follow simple rules. And this chapter begins with an uncomfortable truth that modern medicine has slowly learned. Iron alone does not build healthy blood. Imagine this. You are adding fuel to a car every day. The tank is full, but the engine still sputters. At some point, you stop blaming the fuel and start questioning the engine. That is exactly what happens in thousands of anemia cases. Large population studies published by the World Health Organization and NIH show that a significant number of patients with low hemoglobin do not respond adequately to iron therapy alone, even when iron levels appear sufficient. This does not mean iron is unimportant. It means iron is not the only worker on the job. Hemoglobin is not built by iron acting alone. It is assembled through a coordinated biological process that depends on multiple vitamins, enzymes, and cellular systems working in sequence. If even one part is missing, the whole process slows down. To understand why iron sometimes fails, we need to zoom out. Hemoglobin production happens in the bone marrow, inside microscopic factories that produce red blood cells. This process is called erythropoiesis. Think of it as an assembly line. Iron is a critical raw material. But raw material alone does not create a finished product. You also need instruction manuals, assembly workers, quality control, energy supply. In biological terms, those roles are played by vitamins. Without them, iron sits unused, present, but ineffective. This is why many patients show lab reports that say, iron levels, normal or borderline, hemoglobin, still low. To the patient, it feels illogical. To biology, it makes perfect sense. For decades, anemia was treated almost exclusively as an iron problem, but large-scale data forced a change. According to a landmark WHO review on anemia causes, iron deficiency accounts for less than half of global anemia cases. The rest are linked to vitamin B12 deficiency, folate deficiency, chronic inflammation, absorption disorders, age-related metabolic changes. This was a turning point. It showed that hemoglobin is a system-level issue, not a single nutrient issue. And once this perspective changed, doctors began noticing patterns that had been missed before. Consider a common case described in multiple peer-reviewed studies. A middle-aged or older adult presents with persistent fatigue, pale skin, shortness of breath on exertion. Blood work shows hemoglobin, low iron, low normal or corrected with supplements. Iron is prescribed. Months pass. Symptoms improve slightly, but hemoglobin stalls. Only when vitamin B12 or folate is tested does the missing piece become visible. This pattern has been documented in the United States, Europe, South Asia, Middle Eastern populations, different diets, different lifestyles. Same biological bottleneck. Iron was available, but the body lacked the tools to use it. Why the body cannot just figure it out? A common misconception is that the body will adapt if iron is present. But biology is precise, not improvisational. To build hemoglobin, the body must produce new red blood cells, insert hemoglobin molecules correctly, ensure cells mature and survive long enough to function. Each step requires vitamin-dependent enzymes. If those enzymes are impaired, cells remain immature, hemoglobin synthesis is incomplete. Red cells break down earlier than they should. Iron cannot fix these steps by itself. This is why iron supplementation sometimes improves lab numbers slightly, but fails to restore energy, stamina, or clarity. The structure may exist, but the system is unstable. Now the question arises why this failure is more common after 40 to 50. Age adds another layer. As people cross midlife, several changes quietly occur. Stomach acid production declines. Intestinal absorption efficiency drops. Certain vitamins are absorbed less reliably. Research from the National Institutes of Health shows that vitamin B12 absorption decreases significantly with age, even in people who consume adequate amounts. This creates a dangerous illusion. Diet appears sufficient, supplements are taken. Blood still fails to recover fully, iron is blamed. But iron is not the missing link. This is why anemia in older adults is more often multifactorial, involving several nutrients rather than one. There is another risk when iron is taken blindly. Excess iron that is not properly utilized can accumulate in tissues, increase oxidative stress, worsen inflammation in certain conditions. Medical literature warns against prolonged iron supplementation without identifying the underlying cause of anemia. In simple terms, if iron is not being used, forcing more iron into the system does not solve the problem. It may create a new one. This is why modern guidelines increasingly emphasize cause-based treatment, not assumption-based treatment. In many advanced clinical settings, the first question is no longer, is iron low? It is, why is hemoglobin low? That single shift changes everything. It opens the door to evaluating vitamin B12 status, folate levels, vitamin B6 activity, bone marrow function, absorption capacity. This systems-based approach explains why two people with the same hemoglobin level can have very different underlying problems. And it explains why iron alone works brilliantly for some and fails completely for others. Here's the simplest way to remember this. Iron is the brick. Vitamins are the builders. Without builders, bricks pile up. The house is never completed. Hemoglobin is that house. And when it is incomplete, the entire body feels the consequences: fatigue, weakness, breathlessness, brain fog, even if iron intake looks adequate on paper. This discussion is not about rejecting iron. It is about ending the oversimplification that has misled millions of patients. By understanding why iron alone fails, you are now prepared to understand why some lab reports are misleading, why symptoms persist despite treatment, why vitamins play a controlling role in blood health, and most importantly, you are now ready to meet the real architects of hemoglobin production. That begins with one vitamin in particular, a vitamin that quietly governs red blood cell formation at the deepest level. That is where we go next. Iron may supply the material, but vitamin B12 writes the blueprint. And when that blueprint is missing or damaged, no amount of iron can finish the job. In the next discussion, we uncover how vitamin B12 silently controls red blood cell creation, and why its deficiency often hides in plain sight. There is a reason many people with low hemoglobin feel exhausted long before their blood report looks dangerous. It is because something invisible is failing long before iron numbers fall. That invisible factor is vitamin B12. Unlike iron, vitamin B12 does not build hemoglobin directly. Instead, it controls something even more fundamental. It controls whether red blood cells are built correctly at all. Think back to the analogy from the previous chapter. Iron is the brick. Vitamins are the builders. But vitamin B12 plays an even deeper role. It is the blueprint. Without it, the body cannot properly design new red blood cells, no matter how much iron is available. This is why vitamin B12 deficiency often leads to a specific type of anemia called megaloblastic anemia, where red blood cells are too large, poorly formed, fragile, short-lived. They exist, but they do not work efficiently. And inefficient blood leads to inefficient life. Inside your bone marrow, billions of new red blood cells are created every day. To do this, cells must copy DNA accurately, divide at the right speed, mature into flexible, oxygen-carrying cells. Vitamin B12 is essential for DNA synthesis. Without adequate B12, cell division slows, DNA copying becomes faulty, red blood cells grow abnormally large. Many cells die before entering circulation. This is not a minor defect. It is a foundational failure. According to NIH Medline Plus and Mayo Clinic, B12 deficiency disrupts red blood cell production, even when iron and folate are present. This is why iron therapy alone cannot fix B12-related anemia. Vitamin B12 deficiency is widespread, yet frequently overlooked. Large epidemiological studies in the United States estimate that up to 20% of adults over 60 have borderline or deficient B12 levels. Many younger adults also show subclinical deficiency. What makes B12 deficiency dangerous is not how rare it is, but how quiet it is. Early symptoms often include fatigue, brain fog, mild weakness, shortness of breath with effort. These are easily blamed on stress, aging, poor sleep, busy lifestyle. Meanwhile, red blood cell production continues to decline in the background. One of the most misunderstood aspects of vitamin B12 is absorption. Unlike many vitamins, B12 absorption is complex. It requires adequate stomach acid, a protein called intrinsic factor, healthy intestinal lining, As people age, stomach acid production naturally decreases. Research published in the Journal of the American Medical Association, JAMA, shows that older adults frequently consume enough B12, but absorb far less than expected. This creates a deceptive scenario. Diet looks adequate, supplements may even be taken, blood production still suffers. The problem is not intake. The problem is utilization. In some individuals, B12 deficiency is not dietary at all. It is autoimmune. In a condition known as pernicious anemia, the immune system attacks intrinsic factor, the protein required to absorb vitamin B12. Without intrinsic factor, B12 passes through the gut unused. Red blood cell production fails. Hemoglobin drops steadily. This condition is more common after age 50 in people with autoimmune history and certain genetic backgrounds. Importantly, oral iron or B12 tablets may not work in these cases. This is why identifying the cause matters more than treating blindly. Doctors began noticing a pattern decades ago. Patients with B12 deficiency anemia often present with low hemoglobin, normal, or mildly low iron, enlarged red blood cells on blood smear, neurological symptoms in advanced cases. These neurological symptoms can include tingling or numbness in hands and feet, balance problems, memory issues, mood changes. This is unique to B12 deficiency. Iron deficiency does not affect nerves in this way. That alone tells us B12 is not just about blood. It is about the nervous system and brain. One of the most alarming findings in medical literature is this. Neurological damage from B12 deficiency can occur even before hemoglobin drops significantly. That means a person can have normal hemoglobin, acceptable iron, yet ongoing nerve injury. This is why many experts argue that B12 deficiency should be screened earlier, especially in adults over 40 to 50, because once nerve damage becomes advanced, it may not fully reverse. Consider a case frequently described in clinical journals. A 55-year-old adult reports persistent fatigue, difficulty concentrating, occasional dizziness. Routine blood work shows hemoglobin slightly low, iron borderline. No obvious red flags. Iron supplements are prescribed. Symptoms persist. Only when vitamin B12 is tested does the issue emerge. B12 levels are deficient. Red blood cells show abnormal size. Bone marrow production is impaired. With proper B12 treatment, energy returns, hemoglobin stabilizes, cognitive symptoms improve. This pattern has been documented across continents and healthcare systems. Several modern factors increase B12 deficiency risk: reduced consumption of animal-based foods, long-term use of acid-reducing medications, gastrointestinal disorders, age-related absorption decline. Importantly, even people who eat meat can be deficient. This is why relying on diet alone is not always sufficient. Standard serum B12 tests have limitations. Many experts note that normal lab ranges may still allow functional deficiency. Symptoms can appear before lab values drop below cutoff. This has led some clinicians to use additional markers such as methylmalonic acid, MMA, homocysteine levels. These markers rise when B12 is insufficient at the cellular level. This reinforces a key message. Blood health is not always captured by a single number. Vitamin B12 does not just initiate red blood cell production. It ensures cells divide correctly, cells survive long enough, hemoglobin is packaged efficiently. Without B12, cells are wasted, production slows, oxygen delivery drops. Even with adequate iron, the system underperforms. This is why correcting B12 deficiency often leads to dramatic improvements in energy, sometimes faster than iron therapy alone. If iron is the material and B12 is the blueprint, then there is another nutrient that ensures the blueprint can actually be executed. That nutrient works at the level of DNA replication itself. Without it, even B12 cannot do its job properly. That nutrient is folate. And its role in hemoglobin production is far more central than most people realize. Vitamin B12 designs the plan, but folate supplies the ink that allows cells to copy life correctly. In coming discussion, we will explore how folate deficiency silently sabotages red blood cell formation and why it is especially dangerous during periods of rapid cell turnover. Some problems in the body are loud. Others quietly rewrite the rules of life at the cellular level. Folate deficiency belongs to the second category. You do not feel it immediately. You do not see it clearly on early reports. But when it disrupts red blood cell production, The damage spreads faster than most people realize, because folate does not just help make blood. It helps cells copy themselves correctly. Every red blood cell begins as a rapidly dividing stem cell inside your bone marrow. To become functional, it must copy its DNA accurately, divide at the correct speed, mature into a flexible oxygen carrier. Folate is essential at the exact moment when DNA is being copied. Without enough folate, DNA replication becomes faulty. Cell division slows or stops. Immature cells accumulate. Many cells die before entering circulation. This failure directly reduces hemoglobin levels, not because iron is missing, but because cells cannot multiply properly. Iron deficiency anemia is often easy to explain. But folate deficiency anemia is misunderstood. People assume, if I eat green vegetables, I must be fine. The reality is more complex. Folate deficiency does not always come from low intake. It often comes from increased demand or impaired utilization. This is why folate-related anemia frequently appears during pregnancy and chronic illness, with poor gut absorption and long-term alcohol use in older adults. According to World Health Organization, WHO and NIH, folate deficiency remains a significant contributor to anemia worldwide, even in developed countries. When folate is insufficient, bone marrow cells attempt to divide, but fail mid-process. The result is a specific pattern. Red blood cells become oversized, nuclei remain immature, hemoglobin synthesis becomes inefficient, oxygen delivery drops. This produces megaloblastic anemia, the same category seen in B12 deficiency. However, the cause is different. And so is the solution. Unlike iron stores, folate reserves in the body are limited. You can become deficient within weeks under certain conditions. Medical literature shows rapid folate depletion in acute illness, poor dietary intake, certain medications, gastrointestinal disorders. This explains why some people develop anemia surprisingly fast, even with previously normal blood work. Bone marrow is one of the most active tissues in the body. It produces red blood cells, white blood cells, platelets. This constant production requires flawless DNA replication. Folate acts as a cofactor in nucleotide synthesis, the basic building blocks of DNA. When folate is low, DNA strands cannot form correctly, cell division stalls, blood production slows dramatically. This bottleneck leads to falling hemoglobin, rising fatigue, reduced oxygen delivery to tissues. Folate deficiency rarely announces itself clearly. Early symptoms often include persistent tiredness, reduced exercise tolerance, headaches, difficulty concentrating. These signs are often dismissed as stress or lifestyle fatigue. But at the cellular level, oxygen delivery is already compromised. This mismatch between symptoms and severity is why folate deficiency anemia is frequently diagnosed late. Medical journals describe a recurring scenario. A patient presents with low hemoglobin, normal iron studies, no obvious bleeding, iron therapy shows little improvement. Further testing reveals low folate, enlarged red blood cells, impaired marrow response. After folate correction, hemoglobin begins to rise, fatigue improves, exercise tolerance returns. This pattern has been observed in both developing and developed healthcare systems. Even in countries with food fortification, folate deficiency persists. Reasons include overcooked vegetables destroying folate, processed diets lacking fresh produce, alcohol interfering with absorption, chronic gut inflammation, increased metabolic demand. According to CDC data, certain populations remain at higher risk. Older adults, individuals with gastrointestinal disease, people with long-term medication use. This reinforces a critical concept. Availability does not equal absorption. One of the strongest bodies of evidence for folate's role comes from pregnancy research. Low folate during pregnancy is linked to anemia, neural tube defects, poor fetal growth. This demonstrates folate's central role in DNA formation and rapid cell division. The same mechanism applies to red blood cell production in adults. Folate and B12 work together. But here's the danger. High folate intake can sometimes mask B12 deficiency. This can correct anemia temporarily, allow neurological damage from B12 deficiency to continue unnoticed. This is why medical guidelines emphasize evaluating both nutrients together, not in isolation. Blood health is a system, not a single nutrient problem. Correcting folate deficiency improves cell division, But hemoglobin synthesis still depends on iron availability, B6-mediated heme synthesis, protein sufficiency, bone marrow health. This explains why some patients improve partially, but not fully with folate alone. The system must be rebuilt layer by layer. As people age, gut absorption efficiency declines, chronic inflammation increases, cellular turnover slows. These changes increase folate demand while reducing availability. This is why folate deficiency contributes significantly to anemia in adults over 50, even when diets appear adequate. Many clinicians focus on hemoglobin numbers, but hematology experts emphasize mean corpuscular volume (MCV), red cell morphology, reticulocyte response. Elevated MCV often points toward folate or B12 deficiency. Ignoring these clues delays accurate diagnosis. Untreated folate deficiency leads to progressive anemia, reduced immunity, poor wound healing, increased cardiovascular strain. Oxygen-starved tissues force the heart to work harder. Over time, this can worsen existing heart conditions. Folate does not carry oxygen. It does not bind iron. It does not show dramatic symptoms early. Yet without it, DNA replication fails, red blood cells collapse before maturity, hemoglobin production slows quietly. Folate builds the cells that carry life. But even with perfect cells and enough iron, one more nutrient decides whether hemoglobin is actually formed correctly. That nutrient determines the final step of heme synthesis, and it is often ignored. Iron provides the material. B12 designs the blueprint. Folate allows cells to copy life accurately. But vitamin B6 completes the chemistry that turns all of this into functional hemoglobin. Ongoing discussion will uncover how vitamin B6 quietly governs heme synthesis and why its deficiency can stall hemoglobin production even when everything else appears normal. You can have enough iron. You can have healthy bone marrow. You can even have properly formed red blood cells. And still, hemoglobin can fail, because building hemoglobin is not just about materials. It is about chemistry. And vitamin B6 controls the chemistry that makes hemoglobin functional. Up to this point, you have seen how hemoglobin depends on iron for structure, vitamin B12 for blueprint design, folate for DNA replication. But none of these can complete hemoglobin formation on their own. There is one critical step where iron must be locked into a ring-shaped molecule called heme. That step depends almost entirely on vitamin B6. Without B6, the process slows, stalls, or fails quietly. Vitamin B6, in its active form, pyridoxal 5-phosphate, acts as a coenzyme. That means it does not become part of hemoglobin itself. Instead, it activates enzymes that drive the reactions needed to create heme. Heme is the iron-containing core of hemoglobin. No heme, no hemoglobin. No hemoglobin, no oxygen delivery. This makes vitamin B6 a silent gatekeeper. Iron in your body is useless until it is inserted into heme. Vitamin B6 is required for the very first step of heme synthesis, converting amino acids into porphyrin rings, preparing a site where iron can bind. If this step fails, iron accumulates unused, hemoglobin levels stagnate. Anemia persists despite normal iron. This explains a puzzling clinical pattern. Patients with normal iron studies but low hemoglobin. Vitamin B6 deficiency rarely presents dramatically. Early signs include fatigue, irritability, poor concentration, muscle weakness. These are often attributed to stress, aging, or lifestyle. Meanwhile, hemoglobin production slows behind the scenes. According to NIH and Mayo Clinic, mild B6 deficiency is far more common than reported. Especially in adults over 50, vitamin B6 works closely with protein metabolism. It helps break down amino acids, convert them into usable forms, build the globin portion of hemoglobin. This is where many nutritional plans fail. Iron supplements are prescribed, folate and B12 are added, but protein intake and B6 status are ignored. Hemoglobin is a protein molecule. Without adequate protein and B6, globin chains are poorly synthesized. Hemoglobin remains incomplete. This is one reason anemia persists in people who eat well but lack balanced nutrition. Medical case studies repeatedly describe patients with chronic anemia. Normal iron, normal B12 and folate, poor response to treatment. Further testing reveals low vitamin B6. After correction, hemoglobin rises, energy improves, muscle strength returns. This pattern has been documented in journals such as the American Journal of Clinical Nutrition and Blood. As people age, enzyme efficiency declines, absorption becomes less reliable. Chronic inflammation increases nutrient demand, vitamin B6 requirements increase with age, but intake often decreases. This mismatch contributes to age-related anemia, reduced muscle mass, slower recovery from illness. This is why anemia in older adults is rarely caused by iron alone. Several commonly used medications reduce B6 levels, including certain blood pressure drugs, anti-seizure medications, long-term antibiotics, some anti-inflammatory agents. Patients may develop anemia without realizing medication is part of the cause. This reinforces the importance of nutrient-aware medical evaluation. Standard blood panels do not routinely measure vitamin B6. As a result, deficiency goes undetected, anemia is labeled unexplained. Patients are told to monitor. Meanwhile, hemoglobin production remains impaired. Functional deficiency, where enzymes lack sufficient B6, may exist even when blood levels appear borderline normal. Hemoglobin is not only about oxygen delivery. Vitamin B6 also plays a role in neurotransmitter synthesis, muscle metabolism, glucose regulation. This explains why B6-related anemia often presents with fatigue plus mood changes, muscle weakness plus poor endurance, cognitive fog. These symptoms resolve gradually as hemoglobin and metabolism normalize. Vitamin B6 demand increases with physical activity. Muscle repair, protein turnover, and energy metabolism all require B6. Athletes with restrictive diets or poor recovery nutrition may develop functional anemia, reduced stamina, poor training adaptation. This occurs even when calorie intake seems sufficient. Iron supplementation increases iron availability. But without B6, iron cannot be efficiently incorporated into heme. Excess iron may remain unused. Side effects increase without benefit. This is why some patients experience constipation, nausea, no hemoglobin improvement. The issue is not iron, it is utilization. Hemoglobin production requires iron raw material, B12 cellular blueprint, folate, DNA replication, B6 heme chemistry, protein, globin structure. Remove any one component, the system fails. This systems-based view is increasingly emphasized in hematology research. Population-level data shows older adults with low B6 have higher anemia prevalence. Diets low in whole foods correlate with poor hemoglobin response. Multi-nutrient approaches outperform single-nutrient therapy. These findings challenge outdated treatment models. Chronic low hemoglobin increases cardiovascular strain, cognitive decline risk, frailty in older adults, reduced immune resilience. Vitamin B6 plays a preventive role, not just a corrective one. Iron fills the tank. B12 designs the vehicle. Folate builds the structure. Vitamin B6 turns the engine on. Without it, hemoglobin remains incomplete. And yet, one more factor quietly determines whether this entire system works efficiently day after day. That factor is how well your body absorbs, coordinates, and balances these nutrients together. So far, you have learned how nutrients create hemoglobin. But many people still ask, why does anemia persist even when supplements are taken? The answer lies in absorption, interaction, and hidden deficiencies, especially in adults over 50. The next discussion will uncover why deficiencies hide despite normal lab reports, and how age silently reshapes nutrient metabolism. You take the supplements. You follow the diet. Your lab report comes back within normal range. And yet you still feel weak. This is one of the most frustrating experiences patients face with anemia and low hemoglobin, and it is not imaginary. It is biological. Because normal blood tests do not always mean normal function. Modern medicine relies heavily on laboratory numbers. Hemoglobin within range. Iron stores acceptable. Vitamin B12, borderline but okay. Folate not flagged. So the conclusion is often simple, you're fine, but physiology is not binary. It does not work on red flags alone. Between healthy and deficient lies a large gray zone, where symptoms live quietly and progress slowly. Most standard tests measure quantity, not performance. They answer questions like, how much iron is stored? How much vitamin is circulating? They do not answer, is this nutrient reaching the cells that need it? Are the enzymes actually working? Is absorption effective? Is inflammation blocking utilization? This is known as functional deficiency. It is one of the most under-recognized causes of chronic anemia. As we age, nutrient metabolism changes, even without disease. After age 40 and more noticeably after 50, stomach acid production declines, digestive enzyme output slows, gut lining renewal becomes less efficient. These changes directly affect absorption of iron, vitamin B12, folate, vitamin B6, protein-bound nutrients. So even with adequate intake, delivery fails. Iron and vitamin B12 both require adequate stomach acid for absorption. With age, acid production decreases. Proton pump inhibitors and antacids are commonly used. Chronic gastritis becomes more frequent. This leads to a subtle but critical issue. Nutrients pass through the gut unabsorbed. Blood tests may show acceptable levels, but tissues are undersupplied. Vitamin B12 absorption depends on stomach acid, intrinsic factor, healthy ileum, last part of the intestine. Any disruption leads to failure. Older adults frequently develop atrophic gastritis, reduced intrinsic factor, subclinical malabsorption. Serum B12 may appear low normal, yet neurological and hematological symptoms progress. This is well documented in NIH and British Medical Journal reviews. The important thing is to know that iron absorption is influenced by gut health, inflammation, hormones, competing minerals, diet composition. In older adults and chronically stressed individuals, hepcidin, an iron-regulating hormone, increases. Iron becomes trapped in storage. Blood iron remains unavailable for hemoglobin. This is called functional iron deficiency. Chronic low-grade inflammation increases with age. Conditions like obesity, diabetes, autoimmune disorders, chronic infections all raise inflammatory markers. Inflammation blocks iron release from stores, bone marrow responsiveness, red blood cell production. Lab reports look acceptable, but hemoglobin production slows. Ferritin is often used to assess iron stores. But ferritin is also an acute phase reactant. It rises during inflammation. So a patient can have high ferritin, low usable iron, low hemoglobin. This confuses both patients and clinicians. Research in The Lancet highlights ferritin misinterpretation as a major diagnostic issue in anemia of chronic disease. Hemoglobin is a protein. Iron binds to heme. Heme binds to globin chains. Globin chains are amino acid structures. If protein digestion or absorption is impaired, hemoglobin synthesis falters, muscle mass declines, recovery slows. Older adults often consume less protein and digest it less efficiently. This creates a silent bottleneck. Many commonly prescribed drugs interfere with nutrient absorption. Acid suppressants gives iron, B12, metformin gives B12. Certain antibiotics gives B6. Anti-inflammatory drugs gives gut lining damage. Patients may take these for years without monitoring nutritional impact. Anemia slowly develops without a clear trigger. Bone marrow is not static. With age, stem cell activity declines, response to signals weakens, red cell production becomes less efficient. This does not show up on routine blood tests. It shows up as slower recovery from anemia, reduced response to supplementation, chronic borderline hemoglobin levels. Now the question arises at this point, why eat better is not always enough? Dietary advice often assumes normal digestion, normal absorption, normal metabolism, but aging changes all three. This is why older adults may eat iron-rich foods, take supplements, still show low hemoglobin. The issue is not compliance, it is physiology. Multiple population studies report higher anemia prevalence in adults over 50. Normal iron intake but low hemoglobin, poor response to oral therapy, better outcomes with targeted, supervised treatment. These findings are consistent across developed and developing countries. The body prioritizes survival. It maintains blood levels as long as possible, even if tissues suffer. So symptoms appear first: fatigue, weakness, shortness of breath, brain fog. Labs lag behind. By the time numbers drop, deficiency has been present for months or years. Many labs list wide normal ranges. A value may be normal, but suboptimal for age, activity level, chronic disease burden. For example, B12 at 250 pg/ml may be normal, but neurological symptoms can appear below 400. Clinical context matters more than cutoffs. Anemia in younger adults is often acute and obvious. In older adults, it is gradual, multifactorial, masked by aging assumptions. This leads to underdiagnosis and undertreatment. At this point, there is need to understand anemia is not always a deficiency of intake. It is often a deficiency of absorption, utilization, coordination, especially after 50. This is why single supplement solutions fail. True recovery requires identifying hidden deficiencies, understanding absorption barriers, adjusting expectations with age, supporting the entire system. This is where lifestyle, diet composition, and timing matter as much as nutrients themselves. You now understand why anemia can persist even when tests look normal. The question becomes, what can actually rebuild hemoglobin safely and sustainably, especially as we age? That is exactly where we are going next. Now, our main focus will be on evidence-based dietary strategies, protein balance, and practical lifestyle changes that truly support hemoglobin recovery, not just on paper, but in real life. For many people, the word treatment immediately brings one image to mind: a pill, iron tablets, vitamin capsules, occasional injections. But hemoglobin does not rebuild itself through medication alone. It is rebuilt through systems: digestion, absorption, metabolism, bone marrow activity, and daily habits that quietly decide whether nutrients reach their final destination. Now our discussion is about that system. Not quick fixes, not internet hacks, but practical, evidence-based strategies that actually help the body rebuild hemoglobin, especially after repeated failure or with increasing age. Most anemia advice stops at a simple list: spinach, dates, beetroot, pomegranate. These foods are healthy, but they are incomplete solutions. Hemoglobin is not a single nutrient problem. It is a multi-nutrient construction project. To build one functional red blood cell, the body needs iron for the heme core, protein for globin chains, vitamin B6, heme synthesis, folate, DNA replication, vitamin B12, cell maturation, vitamin C, iron absorption, adequate calories, energy for production. Missing even one slows the entire process. This is where many treatment plans fail. Hemoglobin is a protein molecule. Each red blood cell contains hundreds of millions of hemoglobin units, and every one of them is built on amino acids. If protein intake or absorption is inadequate, iron cannot bind properly, bone marrow output slows, recovery plateaus. Multiple clinical reviews confirm that protein energy malnutrition contributes to anemia even when iron levels appear adequate. This is especially relevant in older adults, individuals on restrictive diets, people with poor appetite or digestive issues. General recommendations are often too low for recovery. For adults with anemia, minimum 0.9 to 1.0 grams protein per kilogram body weight day, optimal during recovery. 1.1 to 1.3 grams per kilogram day, adjusted for kidney health. For a 70 kg adult, that means 75 to 90 grams of protein daily, spread across meals. Not in one sitting, not sporadically, but consistently. Not all protein is equal. High-quality proteins provide all essential amino acids needed for globin synthesis. Best sources: eggs, fish, poultry, lean meat, dairy, when tolerated, legume-grain combinations for plant-based diets. Older adults often eat enough calories, but insufficient high-quality protein, leading to slow hemoglobin recovery. Iron absorption is sensitive. It depends on stomach acidity, timing, competing foods, inflammatory status. Best practices: take iron-rich meals away from tea, coffee, and dairy. Pair iron with vitamin C sources. Avoid taking iron with calcium-rich foods. Heme iron from animal sources absorbs better than non-heme iron, especially in older adults. Vitamin C converts iron into a form the intestine can absorb. Even small amounts matter. Examples: lemon with meals, citrus fruits, bell peppers, tomatoes. Clinical studies show vitamin C can increase non-heme iron absorption by up to 2 to 3 times. This is a simple adjustment with significant impact. Iron fills red cells. Folate and B12 create them. Without adequate levels, cells remain immature. Production slows. Hemoglobin stays low despite iron therapy. Older adults often need higher intake, more bioavailable forms, medical supervision. Dietary sources: folate, leafy greens, legumes, citrus, and B12, animal products or fortified foods. Large meals overwhelm digestion, especially in those with low stomach acid. Smaller, frequent meals. improve nutrient absorption, reduce post-meal fatigue, maintain steady amino acid supply. This pattern supports bone marrow activity better than irregular eating. Blood is mostly water. Dehydration concentrates blood artificially, impairs circulation, worsens fatigue. Adequate hydration supports nutrient transport, kidney clearance, circulatory efficiency. Simple but essential. Nutrition alone cannot override lifestyle signals. Physical activity, gentle movement, improves circulation, enhances oxygen delivery, stimulates bone marrow. Walking, light resistance training, and stretching are effective. Stress reduction. Chronic stress raises cortisol, which suppresses red blood cell production. Mindful breathing, yoga, and sleep regulation support recovery. Sleep. Bone marrow regeneration increases during deep sleep. Poor sleep slows hemoglobin rebuilding. Excessive exertion during severe anemia can worsen symptoms. But complete inactivity reduces circulation. Balanced activity. Morning walks, gentle yoga, gradual progression. This improves oxygen utilization without strain. Dietary strategies work best with medical guidance, especially when hemoglobin is very low. Chronic disease is present. Age-related absorption issues exist. Natural recovery is not the absence of medicine. It is the intelligent use of food, movement, and timing. Successful recovery usually includes adequate protein intake, balanced micronutrients, improved absorption conditions, consistent lifestyle habits, regular monitoring. Not shortcuts. Not extremes, consistency. Up till now, you have learned if hemoglobin has failed to rise before. It does not mean your body cannot recover. It means the system was incomplete. Recovery is possible when all components align. You now understand how hemoglobin is rebuilt, not just in theory, but in daily life. But one critical question remains. How do you maintain these gains long-term and prevent anemia from silently returning? That is exactly where we go next. Now, our focus is on long-term prevention, age-specific monitoring, and how to protect hemoglobin levels for years, not just months. Hemoglobin does not usually collapse overnight. It fades quietly. For most people, the first warning is not a lab report. It is a subtle change in how life feels. Less stamina, slower recovery, foggy thinking, shortness of breath during activities that once felt effortless. By the time hemoglobin levels appear clearly abnormal, the body has often been compensating for months or even years. Here, our discussion is about preventing that silent decline. Not through fear, not through constant testing, but through awareness, structure, and long-term protection. Many people experience this cycle. Low hemoglobin is diagnosed, supplements or injections are started, levels improve, treatment stops, months later, fatigue returns. This is not failure. It is incomplete maintenance. Medical literature consistently shows that hemoglobin recovery requires two phases. Number 1, correction, raising levels into normal range, and number 2 is stabilization, protecting the system that maintains them. Most care plans focus only on phase 1. A lab value is a snapshot. Hemoglobin health is a dynamic process influenced daily by nutrient intake, absorption efficiency, bone marrow activity, inflammation levels, hormonal balance, oxygen demand. When any of these drift, hemoglobin follows. Long-term protection means watching the system, not obsessing over a single number. For healthy adults, once yearly is usually sufficient. For individuals with prior anemia, chronic disease, or age over 50, every 6 months is often appropriate. For those recovering from deficiency, initial follow-ups every 8 to 12 weeks. Then extended intervals once stable monitoring is not weakness. It is prevention. Reference ranges are population averages. Some people feel unwell at values others tolerate easily. For example, a hemoglobin of 12.5 grams DL may be normal on paper, but insufficient for an individual who historically functioned at 14.5. Long-term care respects individual baselines, not just lab cutoffs. After midlife, several shifts occur. Stomach acid declines, absorption efficiency drops, inflammatory markers rise, appetite and protein intake decrease. These changes make maintenance more important than correction. This is why anemia becomes more common with age, even without obvious disease. Many people increase protein during treatment, then relax once labs improve. But bone marrow requires continuous amino acid availability. Long-term recommendations. Maintain adequate protein daily. Spread intake across meals. Prioritize quality over volume. This alone reduces relapse risk significantly. Once iron stores are depleted, rebuilding takes time. Stopping supplementation immediately after normalization often leads to relapse. Clinical guidelines frequently recommend continuing low-dose iron for 2 to 3 months after normalization, dietary maintenance thereafter, always under medical supervision. B12 deficiency often returns silently, especially in older adults, vegetarians, individuals with absorption issues. Maintenance strategies may include periodic supplementation, fortified foods, regular monitoring. Folate intake must remain consistent, particularly in those with increased cell turnover. Chronic low-grade inflammation interferes with iron utilization, bone marrow signaling, red blood cell lifespan. Conditions such as obesity, insulin resistance, chronic stress, autoimmune disorders all increase anemia risk indirectly. Managing inflammation is hemoglobin protection. Bone marrow responds to hormonal cues. Poor sleep elevates cortisol. Chronic stress suppresses erythropoietin signaling. Long-term protection includes consistent sleep routines, stress regulation, balanced activity. These are not lifestyle extras. They are biological necessities. Women, menstrual blood loss, pregnancy history, higher iron requirements. Men, often diagnosed later, symptoms dismissed longer, chronic disease more common triggers. Both require different monitoring strategies. Recurrent low hemoglobin warrants deeper evaluation. Possible causes include gastrointestinal blood loss, absorption disorders, chronic kidney disease, bone marrow suppression. Ignoring recurrence delays diagnosis. Doctors provide diagnostics. Patients provide daily data. Pay attention to exercise tolerance, recovery time, cognitive clarity, cold sensitivity. Symptoms often precede lab changes. People who maintain healthy hemoglobin long-term tend to eat balanced, protein-sufficient diets, monitor periodically, adjust early when symptoms return, avoid extremes, respect age-related changes. They treat hemoglobin as foundational health, not a temporary issue. Hemoglobin effects: brain oxygenation, heart workload, muscle endurance, immune function. Protecting it protects whole body health. Low hemoglobin is not just a lab abnormality. It is a message from the body. A message about oxygen, energy, and resilience. Understanding it gives people back control, not through fear, but through clarity. You now understand that hemoglobin does not work alone. Its strength depends on vitamins, especially B12, B6, and folate. In the next series, we will take each of these vitamins apart. How deficiencies develop, why symptoms are missed, how to correct them intelligently. Because when nutrients fail quietly, knowledge becomes protection.